Good afternoon and welcome to The Doctor is Everywhere, Lessons Learned in the New York Presbyterian Telemedicine Journey, a webinar tweet chat combo from healthsystemcio.com. Just some housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of healthsystemcio.com and I will be your moderator today. We are having a simultaneous tweet chat hosted by our managing editor and director of social media, Kate Gamble. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or if you just want to view the tweet chat, you can do so in the media viewer panel on the right-hand side of your screen. We'll also be using the Q&A panel today. Please send in your questions whenever they occur to you. Leave the default set to all panelists. We'll take those later in the program. And you can see the URL, which is not the one right there, but the one at the bottom of your screen, and also it will be sent out in the chat box. So, our agenda today. First, we're going to hear from our main speakers, Daniel Barchi, SVP and CIO with New-York-Presbyterian, and Dr. Peter Fleischut, Chief Innovation Officer, Chief Medical Operating Officer, and Chief Medical Information Officer with New-York-Presbyterian. So without further delay, I'm going to turn it over to our good friend Daniel Barchi. Daniel, thanks for joining us.
Great. Thanks so much, Anthony and Kate, and thanks for making this happen for Dr. Fleischut and me today. We're happy to be here talking about digital medicine. One of the things we've started to say within New York Presbyterian is that instead of is this telehealth, is it telemedicine, is it digital medicine, more and more, it's just medicine. It's just the way that we're operating. If you look at what we've been doing over the past couple of years, New York-Presbyterian is leading in this area, and one of the things that we've tried to do is tie telemedicine into our larger enterprise. We are a $7 billion enterprise with about 10 hospital campuses across New York's boroughs and region. You see there some of our major hospital systems within the city of New York in Manhattan, primary care hospitals and secondary hospitals, mostly associated with New York-Presbyterian's, Weill Cornell, and Columbia University partners. And then we have a regional hospital network spread across the greater New York region, including a couple of hospitals in Westchester, Hudson Valley, Queens, and now New York-Presbyterian, Brooklyn Methodist. We're a $7 billion institution. We're growing, and we've added a New York-Presbyterian physician medical group. So more and more, we're not only treating acute patients in Manhattan, but we're treating all areas of patient need across the entire enterprise. With our two medical schools, Columbia University and Weill Cornell Medicine are nationally recognized and leading medical schools. They perform the bulk of the medicine at our major campuses in the city of New York, and they are great partners in everything that we do. In many ways, the work that Dr. Peter Fleischut and I do is in concert with them. It's not just New York-Presbyterian. It's New York-Presbyterian, it's Columbia and Weill Cornell working together. And we've had some success. More recently, we're number 6 on the New York-Presbyterian on the National Honor Roll of America's Best Hospitals and continue to move up in those rankings. And we think it's because of the great care that's delivered, but also the way that we're delivering that care. One of the things we've tried to stay away from is what's known as BSOs. Everybody likes to refer to them as bright, shiny objects. It's easy to get enamored of a new $2 million piece of software or a new $50,000 piece of equipment, but more and more what we've found is that healthcare technology is not really about the technology itself. It's really only about 5% technology. It's mostly about people and process. You could say 80% people and 15% process. And we've found that with a lot of the work that we do. I like to joke that this physician here would be no better at doing what he does on this patient if he had the best technology in the world in front of him. It's still the same people and the same processes around him. So as we thought about moving into the world of digital health and telemedicine, it was easy to look first at the past and see what's been done before. So if you go back to 1968, you probably all know Michael Crichton. He's the author who went on to write Jurassic Park and Coma, Andromeda Strain, but in the late 60s, he was a resident and intern at Massachusetts General Hospital, And he wrote a book called Five Patients, and it was the true story about 5 patients treated at MGH and how the process worked for them and what the outcome was. And patient number 4 in the story was a woman in her mid-50s who was on a cross-country flight from California to Boston Logan Airport. And about midway through the flight, she started having some type of chest trouble. And when they landed at Boston Logan, they rushed her off of her plane and into an area of Boston Logan that they were treating as a small medical facility. And they were trying to get in communication with Massachusetts General Hospital about 2.5 miles away from Boston Logan. And through the wonders of 1968, 1969 technology, they connected that woman to a cardiologist at Massachusetts General Hospital in one of the first uses of what is now known as telemedicine. So they had an exam done by a nurse on site, guided by a physician who could see through a black and white picture everything that was going on, and they were able to diagnose what was happening. They were able to write her a script and actually print the script for her locally out of Boston Logan through something that in 1968 or 1969 was called a telewriter. And with that as the basis of technology, we've come to expect that telehealth is what we can expect in the future. Over the years, it hasn't developed really well, but with the growth in technology and the way that we're connected in medicine today and the way we can make this all tie together, we think that we can expand the 1960s version of telemedicine into what we're doing today. And so at New York-Presbyterian, we've developed a program that we're calling NYP OnDemand, a comprehensive suite of digital health services. And I'll let Dr. Peter Fleischut describe some of what we're doing with it already.
Thank you very much, Daniel. A lot of people ask why digital health now, and we're seeing a plethora of services that are existing in other verticals, anything from food to package delivery to transportation to supermarkets. And interestingly enough, we are spending approximately 4.5 hours per day on our mobile devices. So it's a unique opportunity for us to be able to leverage that, to be able to get the expertise of our colleagues from Weill Cornell Medicine and Columbia doctors in the hands of patients locally, regionally, and nationally. Also, in conjunction with that, an important part of this is looking at the consumer research and working with the Health Management Academy and identifying over a 4-month period that about 40% of patients were more willing to do and have a video visit follow-up with their primary care doctor or after a simple surgery or an operation in place of an in-person visit. That was a landmark change that we saw, and a changing in the tide, an opportunity for us to be able to provide people and process and technology in an area where the consumers are very interested in doing this. That being said, they were not as interested in complex surgeries and doing a follow-up after a complex surgery over video. In addition, there's a lot of other drivers that are happening in 2016 and 17. The technology advances in itself with the development of mobile devices, video technology and the quality of that technology, overall consumerism in healthcare, the changing landscape around the credentialing and the medical licensure, also nationally with some of the federal laws coming out, and just overall population health and value-based care and the need for interventions to be able to expand our reach as a health system. This is probably one of the one of the most important parts of the presentation, because as Daniel has mentioned, it was extremely important for us to be able to look at the technology. But as we embark on a new topic, and in this case it happened to be telehealth, it was taking an 8-week framework where we take a deep dive and looking at an organization of where we stand. So the first bar really represents us going out, working with our executive leadership and frontline staff, and determining what, if any, definitions do people have of telehealth. And it was quite interesting to find that we came back with about 25 use cases. So while we're doing that assessment, we're also taking a deep dive and looking at the latest landscape. What are the technology companies that are out there? What are our own capabilities in our existing systems? What things may we have that we've developed in-house, or what are those new technology breakthroughs that may be out there? But once again, only one part of the whole process. knowing that really telehealth is a challenge, not only around the technology, not only around the technology, but we knew we needed to put people and processes around the billing, liability work groups, reimbursement, and see what the latest landscape is right now. And as I mentioned, also doing some consumer research, finding out what actually patients would like to do. So we do this over the course of the first 4 weeks. And then at the 4-week mark, we then decided to put in a pilot. And the purpose of the pilot wasn't to see if that was the company we were going with. It was a purpose is to identify, do patients like this? And is this something that can be operationalized, it can be scaled, and it can be sustained? At the end of this 8-week process, we've thus then been able to put together our strategy as an enterprise, how we felt that we wanted to take on telehealth, and what partners we wanted to be able to work with, and also what internal capabilities we wanted to be able to utilize, and what's really feasibly and possible in the current reimbursement and regulatory landscape. This is an example of our pilot. We were fortunate enough to work with a company, TouchCare, and in this pilot, we just used the simple use case of follow-ups. We looked at post-ED, post-discharge, PCP visit follow-up, and corporate exec wellness. We put the pilot into 4 hospitals over the course of 4 weeks, solely for the purpose of seeing, are the calls successful, are patients satisfied, and what's the overall user experience. Here's some of the results. I'll go all the way to the right. As you can see, over 95% of patients were satisfied with their visits. They absolutely loved it. But as you can see all the way on the left, there was 25% of connection and operational issues. And I like to call that the Pete factor. Sometimes we wait to perfect every single piece of a process to make sure to test whether or not we can go ahead. Here we knew we were going to have issues. We have areas where there may not be as good Wi-Fi coverage, challenges with patients going through the registration process, being able to know that there's another application. But if we tried to figure out every piece of that process to have the perfect pilot, we would have spent 6 months to a year. Instead, we went ahead.
It's important to note there, as Pete was talking about the 25% that weren't working, that that was not in 1969 or in 2004. That was in a pilot that was done in 2015. So as recently as 18 months ago, there were challenges of this magnitude that we still needed to overcome.
Yes, definitely. And so we ended up spending more time as a team focused on those processes and those challenges than fixating on the perfect technology. Ultimately, we ended up deciding, looking at the market and looking at our internal capabilities, we wanted to be able to offer a suite of digital health services. As I would explain, if we were going and building a new hospital, we wouldn't want to just offer one service line or one clinical program. We would want to offer them all, as we're a comprehensive healthcare system. And that's where we came, and at this point came to a 5-pronged strategy, with the first being second opinions. We felt it was essential to be able to improve access to our colleagues at Columbia Doctors and Weill Cornell Medicine by offering second opinions to anyone throughout the country online, and being able to provide them, once we collect their medical records, a asynchronous second opinion in less than 2 days. The second was digital emergency and urgent care. We wanted to be able to provide and improve the capabilities of our patients to be able to get urgent care at home, as a lot of health systems have done, so that they can go onto an app, connect with an emergency physician, and have that urgent care visit from home. And we put that in place first in New York and going now to 3 surrounding states. That being said, to have as much impact as we can to improve the patient experience, we knew we needed to think through the process. And in thinking through that process, we knew we needed to safely and in a high-quality way intervene at the point of care when they're coming into the emergency room. And that's what was the start of digital emergency or express care, where a patient comes in, is evaluated by a nurse in triage, and if a patient meets a certain set of criteria, they're given an option of an in-person visit versus a video visit, where they would go into the room and complete the encounter with a board-certified emergency physician from one of our institutions in a room and be discharged from there. The third is digital schedule appointments and follow-ups. As I mentioned from our consumer research, it was the biggest area for opportunity for patients that we were coming and having a procedure, and then 7 days later having to return, maybe travel a couple hours, give up a day work, and expenses of having to come back and see their physician after a follow-up, and enabling it so that we can do the follow-up from their phone. Fourth was digital consults. Digital consult would be improving inter-hospital consultations, so telestroke, telepsychiatry, telepeds. And I mentioned that there was fifth. The fifth was a combination. One, at the moment when we did our initial assessment, we were going to take on remote patient monitoring. Remote patient monitoring seemed to be important. It's essential. Chronic disease management and chronic care management were very important to us. That being said, we felt that it was too much and we weren't ready to operationalize it in the enterprise level, and we decided to hold off. Instead, we replaced it with something I'll discuss in a minute. So with our digital consults, the traditional being telestroke, as Daniel has laid out for the enterprise, we've grown quite rapidly, acquiring 5 hospitals over the past 2.5 years. So doing and going through the process of ensuring that we're taking all of our digital health programs and expanding them out through the enterprise. Telestroke has been successful for many people probably on this call today and to the webinar in improving the time to be able to treat an ischemic stroke by getting the medicine to the patient faster. Every minute we can get the medicine to the patient when they're having a blockage or an ischemic stroke saves around 2 million brain cells. And on average, we've been able to reduce that by 8 minutes by implementing telestroke and not needing a neurologist in all of our hospitals. We wanted to take that a step further, and this is the 5th prong that I was speaking about, by going and offering mobile telestroke. So we feel that the most important thing we can do is provide healthcare, and provide it as quick and as fast and as efficiently as we can, no matter where we are. And we saw this as an opportunity in providing stroke care. So now a patient could be in the city, call 911, and if it's suspected that they're having signs or symptoms of a stroke, we now can be able to deploy an ambulance out to their home, bring them into the ambulance, CAT scan them in the ambulance to diagnose whether or not they would actually need to have TPA to treat the stroke. And if they did need the TPA, we could administer it there in the field, so that they can get that medicine way before they actually get to the emergency room. And on average, that saves, in addition to the 8-minute reduction, it saves an additional 60 to 70 minutes. And you can do the math with the numbers of how much brain time that you're saving for those patients. And that just started in October of 2015.
What's really important when you think about that program is we don't intend to just deploy one of these mobile stroke units. We intend to deploy several around the city. By doing this in a digital health wireless environment, we don't have to have a neurologist on every one of these ambulances. We can have one neurologist sitting at New-York-Presbyterian doing reads from multiple ambulances at the same time.
Definitely. And with that focus, we've been able to leverage, as Daniel had mentioned, the neurologist not only doing telestroke, but now covering the mobile stroke unit. And operationally, we have a lot of efficiencies as well to expand the expertise to multiple patients. We extended this model to telepsychiatry and felt that it was an opportunity. On average, we had patients waiting up to 24 hours for a consult in some of our regional hospitals that were not fortunate enough to have psychiatry expertise. And now, using the same model as telestroke, we were able to cover telepsych of all of the New York-Presbyterian enterprise and reduce that time down from 24 hours to less than 2 hours. One of our talented pediatric specialists also felt that as an opportunity. We, in some cases, have patients that would come to one of our hospitals and require to be transferred on to our children's specific hospital. And in some cases, that would result in a subsequent discharge. So now, being able to do a telepediatrics visit so that you could remote to the pediatric specialist at the children's hospital and get an assessment by that pediatrics specialist as to determine whether or not they actually have to get transferred, or could we just discharge them home from the surrounding hospitals. and putting that in place. As I mentioned with second opinions, we also wanted to be able to expand coverage nationally and make it easier for patients that may not be able to travel across the country or even in the region, and it was easier and more convenient to be able to get expertise or get an opinion online. Here, working with our colleagues from Weill Cornell and from Columbia Doctors, we were able to cover approximately 80 specialties, and then we'd subsequently move this out to cover international areas as well. As I mentioned, our Express Care initiative, which we've now put into 2 hospitals, working with the Chief of Emergency Medicine at Weill Cornell, Rahul Sharma, in the upper right. We've launched this, and this is the process where the patient will come in and see the person in triage and given an option of an in-person visit or a video visit. To date, we've seen approximately 1,200 patients. The in-person visit is approximately 2.5 hours from admission to discharge, and with Express Care from admission to discharge, it's approximately 34 minutes. Overall, patient satisfaction has been over 95%, and not one patient has backed out of the Express Care going back to the traditional in-person care.
This is one of, Pete, if I could jump in, this is one of the coolest things that Dr. Fleischut and his team have done. He and Dr. Rahul Sharma, our chair of emergency medicine at Weill Cornell, had the idea to do this, and in about 3 weeks from idea to execution, they were starting to see patients via video in our emergency department. And patients are amazed by it. One of the questions we had was, will patients accept this? Dr. Fleischut just mentioned that nobody's backed out of it, and when we say nobody, we mean nobody. We had 2 patients, some of our first patients that came into this program that we put through it needed suture removals. 2 patients back-to-back with suture removals. And you think, well, how do you do suture removals via video? Well, you always have a triage nurse who does the suture removal, then they need to be checked by a physician. So you have the physician do the check via video. We had a 21-year-old patient and an 81-year-old patient came in back-to-back, both for suture removals, and when we followed up with them afterwards and asked them how they liked it, you couldn't tell their responses apart. They both used words like, it was the coolest thing ever, I loved it, I'm going to tell all of my friends. So the patient experience is great for this.
And one of the commonly asked questions that we get when we talk about this is, who are the physicians? So we are working hand in hand with our colleagues at Columbia and Weill Cornell to do this. So we want those patients coming into those EDs getting a board-certified physician from our institutions. That being said, the first question that we got when we launched this, and this was launched in July, was, I don't get it because the physician is 20 feet away in the emergency room. Why would you have somebody go and do a video assessment when the doctor is 20 feet away? And this gets to the component of the scale and the operationalization of this. So I'd use the same analogy when you go to the corner and you go to an ATM machine and there's a teller 20 feet away. We all know that we go to the ATM machine probably 99 out of 100 times to be able to do what we need to do for the simple. And for the complex, we would go onto the teller. So if this was successful, this was basically like an ATM of healthcare. We wanted to be able to expand it to another institution within weeks. And we subsequently went to our Lower Manhattan location 2 weeks later. But what we didn't replicate was the physician workforce. We kept them centralized so we could work hand in hand with them so they could provide coverage to both the Weill Cornell Hospital and to our Lower Manhattan Hospital with the same hub and same focus on the people in the process rather than creating multiple physician experts. And those same physicians now are responsible for providing express care. They also provide urgent care in New York State and 3 surrounding states. And as we move on, and you'll see, covering nursing home coverage and evaluating patients prior to coming back from a nursing home. One important part of this is also of just having one single door front for our patients so that we don't confuse them. There are a ton of applications that exist, patient engagement applications, directions, mobile bill pay, telehealth, asynchronous second opinions. And a very big focus of ours is to make sure that we have one patient application for people to access these services, no matter whether or not it is any of these guides, parking, location. And we've been able to do that and deploy that out across the enterprise, covering those 10 hospitals, even though we've been able to acquire those hospitals so aggressively. And that has involved us having to have some tough conversations with some vendors and choosing some vendors that would be going along with that strategy. So one big part of our outgoing urgent care was to be able to integrate it into one cohesive application for our consumers. And that goes to our app that we've developed that covers these hospitals so that at an enterprise level we can be able to provide services like telehealth, second opinions, urgent care, follow-up care. But on a hospital level, we can be able to provide customized instructions, planning for your stay before, during, and after your stay, EHR and portal access, and simple things like finding your physicians and being able to save a customized physician list. And that gets to the urgent care from home. Over time, probably express care years from now will probably not exist, and patients will default and go back just to their phone and do the video visit from their own home. We feel that it's going to take a little time to get there, and we feel it's important to provide the capability and for us to learn as a health system how to do it and do it well. That being said, it will take a little time. So we do provide it. The visits are around 8 to 10 minutes. The patients can be able to get access to a doctor. This is our scheduled visits for home. One part of it is not even just scheduled visits, but providing the capability for our patients to be able to see an anesthesiologist and meet with an anesthesiologist over a video visit prior to them coming in for a procedure. It's an important point just to decrease anxiety, make it easier for them, reduce an unnecessary trip of them having to come in and do their anesthesia assessment in person, and being able to just go through that assessment from the comfort of their home. Overall, some of the outcomes that we've seen is, as you see in telestroke, approximately an 8-minute reduction time, with our mobile stroke unit around 70 minutes, telepsych, 22-hour reduction, telepeds reducing transfers, and as we're putting in place now, telenursing homes to reduce readmissions and make it easier for the patients in the nursing home. That being said, there's a significant amount of challenges. On a day-to-day basis, this is what we spend time on. As a technology team, we spend more time on the federal and the state regulations, the malpractice, the claims, the clinical staff, and the operations and workflow, and the reimbursement. As Daniel has mentioned before, it's not that we're sitting and talking about bandwidth and video speed and complexities of mobile phones and different versions. That is being taken care of in an excellent way. But this is what we spend our time thinking through. What is the best way that we can expand our access to patients, making it easier, faster, better, and cheaper for our patients in a safe and reliable way?
You make a really good point. On the legal point, it's important to remember that we've built this program not by just leveraging technology we have, but by partnering with a couple of vendors in the industry and then rolling this out across not only the New York-Presbyterian health system, but with Weill Cornell and Columbia at the same time. So there's a lot of degrees of freedom in there. We've got independent physicians, we've got 2 different physician organizations, a health system, and then the customers. And so when you think about the legal challenges of this, there are many issues that can be brought up. Having a legal team that was fully on board and supportive of this and had the time to work with the team through each one of these challenges was really important. But they also have to be open-minded about this. Although it feels different because it's being done by video, at the end of the day, it's just medicine. So as long as the physician is credentialed in the state that he or she is practicing in, it's medicine just delivered through a different medium. So I think that Dr. Fleischut would agree with me. You can have a legal team that gets really bent out of shape about all of the details here, but having one that works with you, understands the complexities, but is willing to work with it is really important.
Yes, I couldn't agree more. I've always found it interesting when we're going through use cases and scenarios and thinking through workflows. And to think that when I was a resident, in certain situations, if I was covering and I had to reach out to my attending, I would pick up the phone and I would call them. And I would discuss the care and discuss the next steps, and they would come in or whatever it may be. Now, because I can have a video visit with my attending, there's other things I have to think about that. And this is where I think as a society we need to work through these issues to really provide the most optimal care for our patients. And the second point that Daniel brought up, which I think is essential, is our legal partners in this have been unbelievable, but inextricably every aspect of the health system has been involved in this and made this a success. Everyone from IT and operations and from development, legal, the medical staff office, even down to facilities, and I say down in the sense of they were a critical component to the success of Express Care and the ability to change the structure of how our emergency room set up and the ability to understand that we would be going through visits at a high turnover rate and being able to work through the process of how we do the things we need to do in those rooms from patient to patient.
Just to emphasize this point one more time, if we had approached this digital health from a purely technology point of view, I don't think that we would have gotten very far at all. The fact that this was vision from our CEO, buy-in from significant physician leadership, and a partnership of all areas of the organization made it what it is.
And that goes into the importance of the governance and going through the process. When we were doing the initial 8-week framework, we actually had to keep a weekly scorecard of all the things that were changing over an 8-week period. Who was working with what companies, for what reason, what were the changes in the regulatory laws, what were the changes from a medical staff operations side. And we still see that now, where we had to put in a governance structure to make sure that we focus on all aspects of delivering digital health and the new use cases that come along with it, as this isn't just one project that we took on, but something that we need to build up a structure and have enterprise governance around what are the best practices to proceed. This has brought in for us also areas and needs for digital access, because now we have other available channels that didn't exist to patients and new ways to be able to present them to those patients. I'll go back to an example of a close family member of mine who went through and had a procedure and needed to drive, give up a day of work, drive to New York City and stay in a hotel for 2 days, and didn't even know that they had the option of being able to do a second opinion online that would have allowed them to be able to get the same result that a surgeon would say, yes, I'm going to operate, and then come back on this date and this time for the procedure. Instead, they had to travel, wait 2 days, see someone in their office, go home, and then come back again. So now that we have these other access options, and as health systems are starting to grow and expand at such massive rates, we need to think through a cohesive enterprise access strategy to be able to provide those options to patients so they can easily get the right doctor at the right time for the right patient. And taking this and bringing back to our core what we are, and what we are by providing healthcare and really reinforcing the ability for us to be able to provide the highest quality, most efficient care. We're currently in the process of building a next generation ambulatory surgery center that consists of ambulatory procedures, endoscopy, infusion, interventional radiology, and eventually women's and children's. So we want to be able to bring some of those concepts into the hospital so that we can really emphasize the engagement prior to a procedure and doing what you can do and be able to do that home, so that when you come within that facility, we're really able to focus our time and energy on what we should be doing and should be done in that building, and then subsequently when they leave, being able to maximize their time at home to be able to connect with them. Okay. Sorry. All right. I'd like to thank everyone. Dana.
The way that Dr. Fleischut wrapped up with our new building is important. We're taking this not only digital to our patients, but we're also turning around and using that technology with the new David H. Koch ambulatory surgery center and ambulatory building that we're rolling out right now. So I would say that the telehealth program at New York-Presbyterian is not just about reaching out to patients remotely. It's embedding digital medicine into every piece that we do. And I think it's been good for our organization because it's pushed us to different ways of delivering medicine than we had considered even 12 or 18 months ago. And with that, Anthony and Kate, we'd like to thank you and take any questions that might be out there.
Excellent. Well, wonderful presentation. I want to thank both of you for delivering it. And now we have some time for questions. So as we mentioned, go ahead and type them into the Q&A box and leave the default set to all panelists, and we will get those in front of our speakers. First question, let me start with you, Dr. Fleischut. How are patients triaged to qualify for an express care visit, and qualify in quotes?
That's an excellent question. So the first way I'd answer it, I'm sure most people on the webinar know, but patients in the emergency room are triaged on a risk basis from an ESI-1 to an ESI-5 level, ESI-1 being the most severe and critical, and ESI-5 being less critical. So what we first did was we focused on those patients that were ESI-4s and 5s that did not require any type of in-person treatment. And when you start to look at the numbers, there's a significant amount of patients that would be coming in that would be classified that. And you can contact me separately, and we can go into more of those specifics. But we looked at patients coming in for colds, things like rashes, as Daniel had mentioned, simple maneuvers like suture removals or wound checks that were happening in our emergency rooms. So we started simple, and then over time saw what fit into the model and build up the criteria.
Very good, very good. Daniel, you mentioned that people and process are as important or more important than the technology issues. What are some of the people and process issues that need to be overcome to institute these type of programs?
Well, as much as technology can bring to our workspace, at the end of the day, these are talented nurses and doctors who are delivering medicine, and they've been trained in delivering medicine in a certain way. We needed to make sure that they were comfortable with the process and felt that they were empowered to make the decisions in the way that they needed to. We never wanted a screen or a keyboard to be between the physician and their patient. We wanted it to enable the relationship. So this is a lot of thought about the layout of the room, the ability to make the patient feel comfortable in the room, the way that we could give the right information to the clinician so he or she knew that they were empowered to make the right decision. It was really about coordinating resources much more than it was implementing any one piece of technology. And I'll take that just a little bit further. It was a lot of testing as well, so you never get this right out of the box. One thing I'm really proud of the way that we rolled it out in New York-Presbyterian was we knew that this was cutting edge, but we weren't developing it for 2 years in a skunk works. We did the right work, we did the testing, and then we rolled it out with a limited number of patients and physicians with all of the right controls and support and safety net around them, so we saw how it worked in a clinical environment. Once we proved that it worked in a repeatable way, then we accelerated, and we're still accelerating. As Dr. Fleischut mentioned, the fact that we've done over 1,300 ED visits to this point via our digital health program in just 6 months shows you where we went, where we were doing just a couple of weeks to the point where we're doing more than 40 a day now, and we expect to continue to accelerate. At some point very soon, we in particular in American medicine in general are going to get to that tipping point where we're comfortable with the idea of digital medicine and we're expecting it.
Very good. I think I'm going to stick with you on this one, Daniel. With CEO support being critical, what was the budget commitment?
Well, we've made a big commitment to this, and it wasn't necessarily dollars, although we've had the dollars necessary to do it. It was partnership. So In our industry partners, we found a couple of technology companies that wanted to work with us so that we were able to leverage our own tools. We had already invested deeply in a good network and core IT infrastructure, so we were able to leverage that for video capability. And then we used resources we had. So we didn't go out and hire a new telehealth team or new docs to do this. We repurposed a lot of the people that we had already. So while there is certainly a budget requirement, and we spent resources and dollars necessary to make this happen, it was more about the time and the energy and the commitment than it was saying, we can only do this because we spent this amount of money, or we can't do it because we can't find that amount of money.
Very good. Dr. Fleischut, let me ask you, obviously we've got you both on the line here. You have a number of titles, but one of them is a CMIO. Daniel's the CIO. Most health systems have those two positions. In terms of launching telemedicine programs, I would imagine this is obviously a key partnership that has to be successful. Just give us your thoughts around what can make a successful partnership among the CIO and the CMIO.
So first is going back to what Daniel said and has been said multiple times, focusing in on the people, our partners, and the process. No matter what project we're embarking on, whether or not it's integration across our 10 hospitals and our 3 physician organizations, or if it's something around telemedicine and leveraging what we have and being able to provide a new service. So focusing in on those areas, to me, is the most successful part of the partnership and working together and providing the platform and the infrastructure to pretty much be able to do anything.
Very good. Daniel, any security issues, concerns, extra steps that the CIOs out there need to be thoughtful of when embarking on these kind of programs?
Sure. So all of the normal security issues that you would expect. We have a really talented Chief Information Security Officer, and Dr. Fleischut and I both feel supported by him and his team. He's been involved in the process throughout, and as we've used our own networks and when we've brought third-party vendors on board, they've gone through a full vetting and ensuring that they adhere to security standards, both for what we're doing on premises and for the way that the patients log into the system from a remote point of view. Other than what you might expect from a normal point of view, there is nothing that is unique solely to telemedicine. We're already doing video conferencing between our doctors. We're already doing phone calls between doctors and patients. We're already sharing data about patients electronically with them directly, with billing companies. So it's many of the same issues that we faced already. We needed to make sure we were following all of our own policies and procedures, but there was nothing unique to digital health that made us take a pause about what we were doing from an information security point of view.
Okay. Let me just ask you both. Not everyone has the resources of a New York-Presbyterian. If you were talking to some of your colleagues out there at smaller organizations, what's a good way for them to sort of get their feet wet, start small, work on a smaller scale, but just are there any sort of low-hanging fruit in this area? I'll start with you, Daniel, and I'll give you the last word, Dr. Fleischut.
Sure. So I think there are many ways to start. Many health systems for years have been doing telestroke programs, which is digital medicine in a very positive way, and it's one of the ways that we had started even before we got deeply into our NYP OnDemand program. I think any hospital or health system or physician group can start with a limited clinical area like a digital health, and then it doesn't have to be all built internally. Although we have plentiful resources, we partnered with vendors who could help us in the second opinions or the video visit space, and anybody can do so. And as most of this is volume-based, whether you're large or small, you're only paying for your usage. So I think that if there is a specific clinical area, anybody can start to play in this space by making the right choices in partnerships.
Dr. Fleischut, any thoughts on that?
Yes, I would completely agree, and I would go back to some of the framework that we use to decide where we wanted to be as a healthcare system. looking internally and externally and looking at any health system or hospital for that matter at its own internal capabilities. What is it already doing? My gut says that a lot of different hospitals are already doing digital medicine and digital health in various ways and formats, whether or not it's to their own employees, to weight loss or wellness programs, or externally facing solutions. And being able to do a quick survey of that, looking again at where the industry is going and what is the regulatory and liability environments, and then where is a system or a hospital do you want to go, and putting forth a strategy. It may just be one of the 4, or it may be 8. I don't think it really matters, and based on the resources and the amount needed, that can be put into play to put forth a strategy. As I explained, we initially started this thinking we were going to take on remote patient monitoring, and we felt it was too much, too big, and not for us at this moment. In the future, we may do it. But if we were a smaller institution, we could have just taken on a little less based on what we had internally.
One more quick question came in from the audience. Dr. Fleischut, how are physicians compensated for these visits when reimbursement is still pending?
Great question. So it depends. I'll go through the suite of services. So for second opinions, right now it is a flat fee that patients pay that goes right on to the physicians. In full transparency, for a second opinion online, it's approximately $800 that was decided upon amongst our physician colleagues. Right off the bat, that seems quite expensive, but I'll go back to that example of my family member that went through, spent about $1,500 in 2 days to come here outside of the physician fees to just get an opinion in person. Secondly, for urgent care, we do the same. For urgent care at home, we charge and have a fee that goes on to our physicians. And for the follow-up care, since it's included in the global payment of the patient, we feel that it's an ideal opportunity because it's not a visit that's being reimbursed at the point of transaction. It's something that can be done and done as a part of the care and a follow-up that we need to do. And we work institutionally with our partners around providing the digital consults, the telepsych, the telestroke, and telepeds.
Excellent, excellent. Well, that is about all we had time for today. When we close out your window, you'll be taken to a post-event survey. If you could take a moment to answer that, we'd appreciate it. I want to thank our speakers very much, Daniel Barchi and Dr. Peter Fleischut, for joining us and sharing what they're up to at New York Presbyterian. You'll receive an email when our archive recording has been posted to our YouTube channel. For those of you with the CHIME CHCIO certification, attending our webinars gets you 1 CEU, so let CHIME know you were here, and if you've asked us to do so, we certainly will. To produce a webinar panel or any type of webinar on the topic of your choice, please contact Nancy Wilcox. And if you need a certificate of attendance for another CEU program, you can use the final slide in this deck. So with that, I want to again thank our attendees, Daniel, Dr. Fleischut, and everybody have a wonderful day. Thank you.